Well, welcome, everybody. I'm just going to give it another minute to let folks join the Zoom, and then we'll get started. Thanks for being here. Welcome, everybody. I know we still have folks that are jumping on here, but I want to get started on time. We have a full slate of presenters today, which we're really excited to hear from. So I'm going to go ahead and get us started. And if folks can see that screen okay, and just give me a nod. Good. All right, well, good afternoon, everybody, and welcome. We really appreciate you joining us today as we present some new data out of New York on the impact of COVID-19 on substance use services delivery. So we really are looking forward to kind of a lively discussion at the end of today's presentation. Just one note, Dr. Kravchuk had an emergent family medical issue and cannot be with us today, but Bennett Allen will be stepping in to provide her presentation. So thanks, Bennett, for that. So before turning it over to our four presenters, so I'm going to give a short introduction to the Chosen Center at Columbia. And so that we're all starting from the same page, I'll just present some general information around COVID, the impact of substance use disorders in the US currently, and some recent data on the intersection of COVID-19 and substance use. So today's seminar is sponsored by the Chosen Center and the Center for Healing of Opioid and Other Substance Use Disorders, Enhancing Intervention Development and Implementation, or more succinctly known as Chosen, is a Columbia-wide initiative chartered about 18 months ago, so a relatively new center here at Columbia. And Chosen is a collaboration between Columbia School of Social Work, Columbia Psychiatry's Division on Substance Use Disorders, and the Irving Institute for Clinical and Translational Research. And we have faculty affiliates across Columbia schools, departments, and divisions, including business, engineering, nursing, informatics, and public health, among others. And Chosen is focused on directly impacting the negative health outcomes caused by opioid and other substance use disorders, including drug overdose and overdose deaths, impaired functioning, lost productivity, and co-occurring psychiatric and physical disorders that we know impact individuals, families, and communities. The center is co-led by four directors, Dr. Elbasell, Levin, Nunez, and Riley. So a little more specifically, Chosen aims to bring together across disciplines, faculty, trainees, and students to design, to develop, to implement novel solutions to the opioid overdose epidemic, as well as other substance use disorders and co-occurring health and mental health issues that commonly travel together. And this is accomplished through an explicit focus on broader social, economic, political, and structural factors, which lead to vulnerabilities and disparities across health outcomes. Chosen also has an active pilot study program. We have 7 pilot studies currently funded and active. So today we're going to be presenting on work that has come out of Chosen's COVID-19 policy work group. There are a number of work groups active within Chosen, and this was one that was convened in early April 2020, a few weeks after the initial COVID-19 lockdown in New York, and following a slate of treatment delivery regulations that were relaxed as part of an initial emergency declaration related to COVID to try and help maintain access to substance use disorder services and treatment. The work group identified a rapid assessment study to design a rapid study design to understand the rollout of these regulations and how they were adopted and implemented, and initial responses to longer-term sustainability to some of these regulations. And really the goal was to help us collect systematic data that would really help inform some of these decisions long-term in terms of policy. The study used mixed qualitative and survey methods, as well as a secondary analysis of a large EHR sourced data set with data collection starting in July of 2020. The study was funded by Chosen, as I mentioned, and was conducted in collaboration with OASS, the New York State Office of Addiction Services and Supports. And this slide just shows you the many folks who contributed to the work around this study. So I just wanted to spend the next couple of minutes just presenting some data to frame the presentations today and what we're seeing in terms of drug overdose deaths before and during COVID-19. So this graph just shows provisional number of drug overdose deaths in the US. You can see over about the last 5 years. And in particular, we'll note that between February 2020 and February of 2021, we saw a 30% increase in overdose deaths, equating to about 95,000 folks. And this comes after a period of time where we were starting to see some leveling off of overdose deaths prior to 2020. New York State has this very similar curve to this national data with a 29.5% increase in overdoses during the same February to February timeframe and close to 3,000 deaths. So we know opioids, and in particular fentanyl and other synthetic analogs, continue to drive overdose deaths, but we're also seeing increases in stimulant-related overdose deaths as well. Slide from the Kaiser Family Foundation shows drug overdose deaths by race ethnicity across 3 time points. So this is January through September of 2018, and that's the navy bar graph line. 2019 is the bright blue line, and 2020 is the orange line. And so we see here again that for 2020, across all racial ethnic groups, we see increases in overdose deaths, but the largest by far among Black and African American and Alaska Native folks, and indicated there by the orange or the red circles. Similarly, when we look at COVID infection, hospitalization and death across racial ethnic groups, we see these same inequities among Black and American Indian Alaska Native people, as well as Hispanic people when compared to white people in the US. This is adjusted for age with data through October of 2021. You can see there are about 2 to 3 times the number of cases, hospitalizations, and death in Black and American Indian Alaska Native groups. Just to finish up here, I wanted to present just a little bit of data that's come out within the last year of studies demonstrating greater negative health outcomes among people with substance use disorders during the pandemic. So there's been an increase in positive alcohol screens and visits for acute overdose and intoxication in the emergency departments. There's been also substance use associated with lower COVID-19 guideline adherence and greater odds of COVID infection, and thus, not surprisingly, greater risk for COVID and worse outcomes from COVID for people with substance use disorders, and in particular, folks that have opioid use disorder and tobacco use disorder. And even among vaccinated people with substance use disorder, there's some research showing that COVID infection rates were twice as high compared to non-substance use disorder populations. This is likely the result of people with substance use disorders having greater comorbidities and risk related to economic determinants and other social determinants of health. And both of those leave significant room for intervention potential. So overall, when we look at COVID substance use disorders and overdose, we see a significant intersection among all of these issues and the urgent need to center and address structural inequities. So keeping that in mind, I want to go ahead and move to our presentations for today. And these are the order of the presentations. And we're going to have our presenters go in order. We're going to save questions until the end. So we should have about 20 minutes or so for some active discussion. And so I will ask each of our presenters to go ahead and introduce themselves at the beginning of their presentations. And we're going to start off with Bennett Allen, NYU's School of Medicine. So let me stop sharing, Bennett, so you can start, and we will turn it over to you.
Sure thing. Thanks so much. I'll share my slides. Can you all see those okay? Is that coming up? Great. Sure, so thanks so much, everyone. My name is Bennett Allen. I'm a PhD student in epidemiology here at the School of Medicine at NYU and affiliated with the Center for Opioid Epidemiology and Policy. And as mentioned, Dr. Krawczyk was not able to join us this afternoon, but just noting up front that she prepared this presentation, and it's really my pleasure to step in and share some of her and our work with you all today, as well as noting up front our many collaborators on this project. This is just one piece of a much larger portfolio of work with folks across NYU and Columbia. So thanks for having me. So as Dr. Campbell discussed, there are multiple reasons for why the COVID-19 pandemic has affected people with substance use disorders particularly severely. So on the left, you see a social ecological model adapted from a recent paper by Ethan Cowan and colleagues, really illustrating the multiple ways in which people with substance use disorders and opioid use disorder in particular might be impacted by COVID-19. So from the individual level, moving through networks and families, communities, up to the structural level of factors that might impact COVID-19 outcomes. But really thinking about this in terms of a bidirectional risk relationship, both of how COVID-19 might impact substance use and overdose risk, and also how substance use and overdose might impact COVID-19 risk. So today I'll really be focusing on that second arrow on the bottom there, that relationship. I'm sure we all remember that New York City was an early COVID hotspot. Thinking back to those first few weeks and months when Manhattan was empty, I'm sure is imprinted in all of us. But given this, we're really interested in how COVID-19 impacted people here with substance use disorders here in New York City, in particular, given that shock, we would call it. We're particularly interested in disparities by race and economics. The epidemic of COVID-19 and opioid overdose have not impacted all communities equally. So on the left, you'll see that some of those neighborhoods most impacted by COVID-19 overlap to a large degree with those neighborhoods on the right that experience the highest rates of opioid overdose mortality, in particular thinking around the South Bronx. And areas of East Queens, West Queens, sorry. So Dr. Krawczyk and I, with colleagues at NYU, conducted a pilot study, really a very preliminary work using electronic health record data from NYU Langone, just to see what we were seeing in those earliest months of the pandemic with respect to substance use disorders. Indeed, we did find a strong association. We saw higher rates of hospitalization for all substance use disorders, as well as drug overdose, with the exception of cocaine use disorder, as well as higher rates of ICU admission at NYU Langone for all substance use disorders and drug overdose, except for cannabis and cocaine use disorders. But really, as a pilot study, this work generated many more questions than answers, and had many limitations. So our preliminary work really opened up new avenues for us to explore. So really thinking in particular, are we seeing similar findings with respect to substance use disorders in a larger, more diverse and citywide sample? NYU Langone, the patient population is more Manhattan-based and tends to be whiter and more affluent than the rest of New York City, so not really reflective of the diversity of the city. Additionally, are there disparities in outcomes based on race and ethnicity, given what we might find Amy, that's you in the chat. And given what we might find with opioid overdose, and focus, given that our findings were the strongest with respect to opioid use disorder and opioid overdose, really thinking about, are these two conditions and sort of opioid use disorder and histories of opioid overdose associated with stronger negative COVID-19 outcomes, and really drilling down into opioids. So we've begun to work with a larger database with our collaborators at Columbia as part of this larger team, using much more data in a much longer time period, using the Insight Clinical Research Network, which is the largest clinical research network in the nation, and pools aggregating electronic health record data from 5 academic medical centers across New York City. So the Insight Network has a total of 12 million patients, approximately, which really more or less reflects the racial, ethnic, and socioeconomic diversity of the New York City population. Additionally, helping bridge the extensive set of healthcare services offered across what is an otherwise quite fragmented healthcare landscape, as we all know. So with this study, using this larger population, we have approximately 116,000 COVID-19 patients, 116,500. And as you can see, about just over 3% of these patients had any history of substance use disorder, so lifetime history of substance use disorder. Most prevalent alcohol use disorder, followed by cannabis, opioid, and cocaine use disorders. A little over 900 patients had any history of drug overdose, and a little over 600 had opioid overdose in particular. And notably within this population, we're really seeing sort of extraordinary rates of poor COVID-19 outcomes. So, nearly 57% were hospitalized for COVID-19, over 8% were intubated, and nearly 6% experienced sepsis. Quite surprising, 16% had acute kidney failure, and just over 9% died either while in the hospital or immediately in the 2 weeks post-discharge from their COVID hospitalization. So for the first analysis we're working on, we really want to take a big picture look at assessing the relationship between substance use disorder history and COVID-19 severity. So we're looking across those 5 outcomes: hospitalization, intubation, sepsis, kidney failure, and death. Looking at our range of substance use predictors, substance use disorder predictors, and a constellation of demographics and comorbidities that in particular were selected as covariates given their known associations from other work with poor COVID-19 outcomes. So just very preliminarily, our findings we're seeing quite elevated risks of all outcomes associated with opioid use disorder in particular, and really confirming our prior work from earlier last year, limited to the NYU population. So in this larger sample, we are seeing, as you can see, an odds ratio of over 2.5 for hospitalization and over 1.67 for death, looking at opioid use disorder in particular. So sort of what we really want to sort of start to approach this question of race disparities. So thinking around stratifying our outcomes by race and ethnicity among patients with substance use disorders. I know this is a lot of data to put up on one slide, but really just wanted to share that, although this is sort of like a first step in our, as we move toward an analysis, really we're starting to see potentially the emerging patterns of disparities by race and ethnicity across these COVID-19 outcomes, and that these outcomes are not necessarily distributed equally across all racial and ethnic groups. For our second analysis, we wanted to look at the relationship between opioid use disorder and opioid overdose history with COVID-19 severity and risk factors among this group, given what we've seen with the very high rates and very high risk experienced by those patients. So again, looking at the same outcomes and using prior diagnosis of opioid use disorder and opioid overdose history as our exposures. Again, looking at sort of these many risk factors, both for opioid overdose and opioid use disorder, as well as for COVID-19, including some that might be unique to opioid use disorder patients like hepatitis C and HIV. And again, very preliminarily, we're seeing very high rates of death and hospitalization, severe sepsis, the high risk among these patients, among both patients' populations. Both for patients that are experiencing exclusively one or the other of opioid use disorder or opioid overdose, or patients who are experiencing either of these health conditions. So just quickly to sort of wrap up and summarize, patients with substance use disorders are facing disproportionate risk of COVID-19 illness and progression. I feel like our work and work from really around the world is sort of helping to establish this. Patients with opioid use disorder or histories of opioid overdose are at particularly high risk, notably. And patients with substance use disorders, we might be demonstrating the disparities in the risk of poor COVID-19 outcomes by race ethnicity. So our next steps really are to begin to test for effect modification by race, ethnicity, and gender, and really drill down into some more robust analyses around potential disparities there, looking for particular risk factors for severe COVID outcomes among patients with substance use disorders, and of course, looking at the relationship between other psychiatric conditions and COVID-19, including comorbid substance use and psychiatric disorders. Just some future directions for our work. Research is really needed to understand the mechanisms around these risk factors. So in particular, really thinking around questions around presentation, timing, and access to care as sort of critical avenues for research moving forward. Our sort of clinical and public health efforts should really focus on reducing the COVID-19 risk among patients with substance use disorders, in particular thinking about reduced stigma in healthcare settings. Just again, to close, I want to acknowledge our collaborators at Columbia and NYU, as well as Chosen for supporting this work and hosting this talk today. And of course, the Insight Clinical Research Network for supporting our wonderful access to data. Finally, just putting up my email and Dr. Krawczyk's email, and I believe Dr. Krawczyk is very active on Twitter, so that her Twitter is there as well, if folks use that. So thanks very much. I'll turn it back to you, Amy.
Great. Thank you so much, Brennan. Appreciate that. And now we're going to turn it over to Dr. Brandy Henry, who's an assistant professor at Penn State College of Education and a former postdoc here at Columbia. So keeping it in the family. Brandy, I'll turn it over to you.
Thanks so much, Dr. Campbell. I really appreciate it. Yeah, and I'm a new assistant professor at Penn State. So this work is pretty much exclusively, well, actually, I think basically exclusively done while I was at Columbia. So I'm still excited to be continuing to collaborate, working with Bennett as well on that project, and seeing all the really important findings that we're having with this important project. So the sub-study of this larger project that I'll be talking about today is focused on policymaker perspectives on substance use service policy development and implementation that happened during the COVID-19 pandemic. And some of the findings that I'll be highlighting relate to innovations for health equity. And as you heard earlier, we started this work in the very beginning of the COVID-19 pandemic. And at that time, and we continue to be experiencing an ongoing epidemic of opioid overdoses. So we're layering the COVID-19 pandemic on top of that. And what we were already observing and experiencing and knew from research was that overdose risk wasn't hitting all populations evenly. The people who are experiencing structural violence, such as incarceration, lack of housing, chronic illness, all of these things, these people are at much higher risk of opioid overdose to start with. And then when you put on top of that marginalized racial and ethnic identities, like you heard earlier, people are at an even higher risk of death from opioid overdose. And then along comes COVID-19 to really just amplify this crisis. So now not only are people facing risk of death by overdose, but they're also facing risk of death by COVID. And so ourselves and other researchers, policymakers, people out in the community who are advocates and drug users themselves, were very concerned in the initial stages of the COVID pandemic around what was going to happen with this very vulnerable population. And so there was a lot of concern around what was going to happen to them when drug supply became more unpredictable, when you couldn't predict, for example, how much fentanyl might be in something you were purchasing, when it became more difficult to access syringes, clean syringes, when people experienced higher rates of social isolation, which can increase risk of death by overdose. One, because when you use alone, there's no one to revive you with Narcan, and two, the compounding mental health effects that might have, which could lead to relapse. And then finally, what was going to happen to service access? We saw transportation becoming more complicated. We saw funding structures collapsing, and people just having a hard time getting anywhere. And so we were really worried, how was this going to impact people? And as I mentioned, we weren't the only ones thinking about this. Policymakers were on it as well. And at the national and at the state level, people who are in charge of policies were doing something very, very quickly and very, really innovating rapidly, which is sort of unusual. But we were in a crisis. There were emergency declarations that changed the way that policies were made. And so very quickly we saw changes in three main areas, which is what this study is going to focus on. So policies were changed that modified the way that telehealth could be delivered. It increased reimbursement structures, allowed for telephonic only reimbursement of telehealth. Previously, video options were also required. And there were also only a limited number of HIPAA compliant platforms that were allowed to be used for reimbursement. So all of that changed. It made it much more flexible for patients to receive and providers to deliver telehealth services. And the idea behind this was to increase access to people who were socially distancing or isolating. There were also policy changes around medication dosing, particularly for methadone. So it allowed patients greater flexibility to take home more doses of methadone. It also allowed for home delivery of methadone, and it allowed Narcan to be mailed. Again, to promote social distancing so that people didn't have to come into clinics every day. And then finally, there were some changes around provider scope of practice, which eased out of state medical practicing. So mainly allowing providers to work across state lines. So a provider in their house in New York City could have a telehealth appointment, for example, with a patient in New Jersey, even if they're not licensed in New Jersey. And this allowed everyone to stay home and socially distance. There were also changes to who is considered an essential worker. So syringe service workers were elevated to essential employees at one point during the pandemic. So all these changes happened, and people are feeling pretty excited about how this might help to stave off some of these negative effects that we were worried about. But we weren't sure how it was going to play out. And so part of this research is really to try and understand in this rapid development of new policies, how did it play out? Did it play out in sort of this traditional top-down method where policies are developed in a very formal structure by policymakers and then disseminated to the public and with opportunities for public input at very specific and formal times, often via formal public hearings or opportunities for public comment, and then rolled out in a pretty linear fashion where the end users kind of get the policy as it's been developed and then have to decide to adopt, implement, and maintain it with this sort of really hierarchical model. And this figure on the screen is a framework that describes that traditional model of policy development and dissemination. And so one of our main questions is this how it happened during the COVID-19 pandemic, or were there differences? Did this process deviate in some way? And so that's one of the main aims of this study, is to look at the process of how these regulations changes to substance use services were changed. And then also from the perspective of policymakers, how were these adopted, implemented, and what did they see as the future going forward? Were there things that they perceived impacts that they saw in terms of these policies being useful, having unintended consequences, and where did they see opportunities for things to be maintained or new innovations going forward to try and address this already very vulnerable population? So to try and answer this question, we used a qualitative approach. So we had semi-structured qualitative interviews with policymakers in New York State that were conducted between July and October of 2020. And there were 14 people we talked to across 10 organizations. So a few organizations sent us multiple representatives. And the organizations spanned state government, local government, non-governmental agencies, and professional organizations. And then we used a framework analysis approach to analyze the data, the qualitative data, using both inductive and deductive approaches. So specifically, we wanted to know how does what we're hearing happen in terms of the process of policy development, how does that map to the pre-existing framework we came in with? And then how does it deviate from it? And what are some unexpected themes? So we wanted to have opportunity to hear all of those different things and have emergent themes as well as things that we might have expected. And this figure shows our main results. And so as you know, at first glance, you might say, this looks nothing like that other figure. There's no top and there's no bottom, it's a circle and the arrows go both ways. And so that is by design to highlight that the process that policymakers described using to develop, disseminate, and then roll out these policy changes was very different than how things normally occurred. And so what they described as a real flattened power structure and a sense of camaraderie between policymakers and end users of policies, so specifically service providers and people who use drugs themselves. And so there were ongoing conversations between all of these groups, sometimes weekly, talking about what was going on the ground, what was needed, how could they write policies to address those needs, and then how could they adjust policies they had already disseminated to improve access to services primarily. And this is something that's not often seen before, this back and forth process, and the opportunity really to pilot policies in real time. Usually this process is much slower and more drawn out, and that's not necessarily a bad thing that it's slower. But what we saw is that there was a lot of communication and a real sense of, at least from the policymakers that we spoke to, that they were sort of all in this together and that they were able to really affect important change. And so people were very motivated to continue working like long hours, nights and weekends in this crisis to try and really make a difference. And so then what we heard in terms of as the cycle moves forward, policymakers identified that there were some barriers to the adoption of policies initially. So for example, the medication supply chain, there are actually in the US policies at the federal level that dictate how many, the amount of controlled substances that can be manufactured and how they're distributed through the country. And so initially they heard very quickly from methadone clinics, we're not going to be able to dispense all this methadone, all these take homes. We're not going to be able to give people 2 weeks of medication. We don't have that backlog. We only have enough for the usual flow of medication, which is daily dosing. So in receiving that feedback, those policies were able to be changed very quickly to meet end user needs. We also heard about how historic lack of integration between various types of substance use services and general health and mental health has created barriers for the implementation of some of these policies. So there was greater flexibility, but it was really, the implementation of it was confused by, for example, their different license types. for mental health and substance use providers. Some agencies hold multiple licenses. They were trying to make sense of different streams of information from their different licensors. And so one of the things policymakers did to address that is really come together at the state side and try and streamline the flow of information and coordinate amongst them to help improve that integration. Although the continued lack of formal integration was cited as something that needs to continue to be worked on in the future to improve ongoing substance use services. And then finally, we asked them, what were the perceived impacts of all these changes? And they talked a lot about really being excited about increased flexibility and the ability to deliver services in a lower barrier way. So they saw particularly telehealth as reducing a lot of barriers to people getting in the door and getting services, which they thought was really important. And that more flexible funding streams allowed providers to literally meet people where they were at. People didn't even have to come to the clinic. They could talk to them on the phone wherever they were. Some places even talked about having like conversations with clients as they're standing on the corner using a payphone. So really trying to innovate, reaching people. They also talked about how there were changes that were happening in tandem around criminal justice reform that were potentially really synergistic to increasing access to care and improving support for harm reduction services, and that they hoped that those things could continue as well. And then finally, there was a really big call for best practice guidelines. So there's a lot of enthusiasm around all this flexibility, but also no guidance in how to use any of these new approaches. And so they wanted to know what patients does telephonic only telehealth work best for? They worried that maybe there are some patients that really benefit from the structure of coming, for example, daily to get their methadone dose. How can we identify who those patients are and make sure they get the support they need, but also that we're not punishing people who don't need to come in every day, and we're giving them the flexibility they need to go out and do other things in their life, like work and take care of their kids and thrive in those areas. And so I think going forward, some research, hopefully our research can help guide this, and the other projects in the Chosen study can help inform who are those patient populations that benefit from the different areas of flexibility that existed underneath these new policy changes. And then finally, I think really exciting in terms of her implications on equity is that the way that the policies were developed cooperatively with end users really highlights that co-development and co-production of policies is feasible. It's not something that's historically happened in the US and most other countries, but it's something that can happen and something that was noted to happen also in a similar study of policy changes, not for substance use, but other policies in the United Kingdom, that during COVID, there was this co-production going on, and that what we saw and what they saw as well was that this facilitates buy-in from the communities who are going to actually be adopting and implementing the policies, and that can increase support for improving health outcomes for marginalized populations. So actually bringing people who are closest to the problem into the policy-making process so they can say, hey, this is what we need to see in a policy, and then giving them the power to implement it later. And so flattening those power structures is something that I think has huge impacts potentially for health equity. And again, addressing some of these barriers to health that relate to structural violence, which I mentioned before is a huge problem for substance users in general. And I wish I could talk more about our project, but I have to turn it over to my other presenters. But if you want to read more details, our paper describing the study came out a month or two ago in JSAT. So this is what it looks like. You can Google it. This is the title, the authors. You can email me, I'll shoot you a copy. And I look forward to answering any of your questions at the end. Thank you so much.
Thanks so much, Brandy. Really appreciate that. And as Dr. Hunt is queuing up his slides, I'll just remind folks to please enter any questions that might come up for you as we're going through the presentations, and we'll try to address all of those at the end in kind of a group discussion. So I'll now turn it over to Dr. Timothy Hunt, who is an associate research scientist and the associate director of the social intervention group at Columbia University School of Social Work. So take it over, Tim.
Thank you, Dr. Campbell, Dr. Henry and Bennett for really doing a great job of kind of laying the groundwork for the reason for this seminar and the reason for our studies. And we're hoping that the chosen center will really add to some of the solutions here to address substance use disorder equity. At the same time, we're addressing this crisis and collision of COVID. The work today I'm going to highlight is the third phase of a study you just heard Dr. Henry speaking about, giving voice to the providers in New York State around the way they adapted, they adopted, they implemented, and then shared with us some of the implementation barriers and actually facilitators of these new regulations, and really with a reflection on in what way have these changes impacted worsened disparities, or in some ways, are they opportunities for increased equity in healthcare? So just give a quick background. I'm going to refer back to some of what you've heard already, that they laid the groundwork, the importance of this work with substance use disorder, the risk factors that are associated with COVID, briefly describe the methodology around this particular sub-study, and then to give some preliminary initial findings from this qualitative study that we are now going to present, and actually point to some future research and talk to our implementers and state partners on how we can really change the way substance use services are provided. This is an opportunity from this crisis to see change happening. There are some limitations, and I look forward to discussions with you about questions you have and really opportunities. So as you heard Dr. Henry talk about this three-phase approach, you'll hear in a bit also from Amar about, from a GIS point of view, the survey implemented that we did as part of the study. You just heard from Dr. Henry, phase one. I'm going to reflect on phase three, where we interviewed providers, 29 interviews from 30 organizations, and give you some hint about some of the themes that emerged from that and how they responded to COVID. Our main aims here are really to look at the multi-level facilitators and barriers to implementing these new regulations, and then to give some direction and suggestions to our state and federal partners who are going to make decisions around should these regulations stay, and which ones were effective and which ones really changed or enhanced service provision for those with substance use disorder, and particularly those with opioid use disorder. We were all there. We know you've just heard from Brandy talking about all the regulations that did change. Some of them that had been in the work for decades and had been stuck really moved forward with changes. And we're going to talk about some of the organizational cultures that changed during this period. But as we see on the federal level, SAMHSA really moved forward with changing a lot of these regulations along with the DEA. I'm not going to go into these details because you just heard a lot of reference about what changed, but certainly from our materials today, we'll share with you the highlights of changes you heard Dr. Henry talk about, really transforming telehealth, telepractice. Whereas before the pandemic, less than 1% of service provision was done by telepractice. Now it's upward to 27, 28, and much more. We're actually implementing telehealth services. We saw changes in methadone, where the culture of methadone has been so traditionally controlling of patients and the way those medications are distributed. They've been used for rewards and control issues in the way that they were distributed. Programs quickly moved into changing the way that they provided take-home medications. So we'll talk about a bit about telemedicine and how it has moved forward, and actually how it might be beneficial based from the provider point of view, but also that there are some challenges, especially when it comes to technology. You heard already a bit about the way medication dosing shifted and changed. The take-home, the role of the pharmacists, really transformed during this period, and then really highlighted for organizations to stay afloat. How are they being reimbursed? the bundled approach to reimbursement versus per visit reimbursement, and how were organizations to stay afloat based on that kind of funding strategy, and what can we move forward with to make programs be able to feel sustainable and not have to, and be patient-centered, and know because they were going to have funding. Issues around confidentiality and licensing were loosened, and you just heard also with naloxone or Narcan, and the way immediately it was emphasized that syringe programs and harm reduction were elevated to essential workers, and at the same time, you will hear from them how they did not feel valued in this process as well. So the disproportionate burden, again, on those with substance use disorder and COVID has already been made clear. The pre-existing conditions that also people have, this very large study from 360 hospitals, 317,000 providers in 50 states, reduced from 73 million down to 12 million with a substance use disorder. And of those who had COVID, 7 million, looking at these, some common characteristics of risk, as you see here, both pre-existing and substance use related risk that put them both at risk for COVID itself, but also for poorer outcomes, especially for the African Americans who are a significantly greater risk for hospitalization and even death from COVID. The structural and social determinants really highlighted here, and you'll see from the voices of the providers around homelessness, incarceration issues that inhibited the access to care during this period. There was a very large study here also in California that did a review of 8 studies looking at telehealth and telehealth practice. The effectiveness in general is as equal to in-person as you see with these 7 studies, but also even methadone was improved some retention as well when it comes to the take-home and flexibility of the program. It was not equally effective as seen from providers in California who saw that individual work was enhanced, but sometimes group work was more difficult. Also, medication management was a bit more challenging, especially during assessment in those earlier phases, and especially concern around those patients who were not as stable as others. So that's just a quick highlight of some of the changes we've seen. This particular study, as Brandy said, guided by 2 different frameworks. You saw the adoption policy framework, but also this we're using more closely the consolidated framework for implementation research. Looking at the data, it helped guide our instruments, our semi-structured interview guide. It also is guiding our analysis as we look at both the inner, the outer settings, but actually the intervention itself being the change of policies. And the individual level is both the patient as well as the provider in this particular study. These semi-structured interviews were conducted between July and December of last year, and 30 to 45 minutes with $75 compensation. These were video recorded and transcribed. The sample itself, as I mentioned earlier, was 29, most identified as medical or program or clinical directors. You see the context in which they volunteered to be a part of the study. This study, again, these came from the surveyed participants, the 227 who were surveyed, volunteered to be interviewed. And you see the range from harm reduction programs, outpatient treatment programs, the office-based treatment programs, as well as the OTPs, the opioid treatment programs. So in our initial analysis, we are seeing the data form and cluster around these 4 main domains around telehealth itself, around logistics and the challenges of method of treatment, whether, for example, group or individual, the logistics around billing and medication access. We saw issues around treatment philosophy and the context, and how sometimes programs can be stuck in doing things the way we usually do them, rather than being innovative. And then across systems issue, certainly sharing across systems such as the criminal and law enforcement systems, mental health and substance use and parity of those treatments, and then certainly the billing system in that outer context. We just want to highlight a few of the findings here, starting with the individual provider consumer level. we want the words to come alive, so we're giving some examples here from the interviews. There's a lot of impediments around technology, the access to technology, around telehealth and video health. So just general, we cannot assume that people even have telephones or phones at all, much less smartphones. This particular provider talked about many of their clients coming from incarceration. So 20% of our patients didn't have a telephone, and we're doing telebuprenorphine because they're calling from a Wi-Fi tower, or they're calling from a social worker's phone or from a girlfriend's phone. So the ability to adapt or be sensitive to those kind of differences, the lack of phone data in order to use a smartphone itself. Privacy issues, again, where were they calling from? Was this a shelter? Was it congregate care? Was it at home where their family may not have known they have a substance use disorder? This provider said, but then there are significant issues of privacy. There are privacy issues. I don't know if we've come to this actually. I should have mentioned this before, that's another barrier is privacy. I've forgotten. People don't have adequate privacy in their homes, and other people in their homes are listening in. Again, numerous impediments to technology. This around Wi-Fi access. Now, this is both a facilitator and a barrier for those in rural areas to be able to reach to programs where even methadone programs do not exist at all. At the same time, what about broadband in those areas and the challenges there? What about the age appropriate in those who are older and not used to using technology, video conferencing, Zoom, and other platforms? So how do you orient the patient to that, and what time does it take to do that? The unstable housing, again, around the difficulty to do telehealth. And then there are many who just prefer the phone itself also at times, and the consideration of those with co-occurring disorders that may prefer, because of fears and anxieties, that they prefer to call into a session. So here you see one provider talking about those with co-occurring patients. A lot of them had trouble like kind of dealing with the whole Zoom thing, the telepractice thing. So again, being able to just use the phone was very advantageous to us to keep them intact. And they pretty much were the patients we brought back into services because they really wanted to come back. They're very isolated generally because of their mental illness. And then you're putting COVID on top of that. So the multiple levels of stress that our patients in New York State experiencing. To highlight the social determinants that impact the delivery of services here on the individual or consumer level. I've already mentioned unstable housing and shelter and congregate care issues. This provider says, yeah. I mean, the patients that I take care of, some of them structurally vulnerable, they're not middle class, they're people of color. They're people who live in prisons and jails. They're people who have chaotic substance use, who might be using a syringe exchange. And so they might have housing instability. A lot of them live in shelter. So yeah, telehealth software did not work. Safety issues, again, in shelters. How do you, if you pick up your medication, do you have a place to store it? So this provider was addressing that. Could they allow take home? Could they suggest take home? And where were they going to store those medications for the 28 days or 14 days that they might have allowed? The legal issues that came up, again, those who were disconnected even from the ability to go to court to resolve their issues or to see their probation officers, often that was cut off. And so this time, you're cut off from your provider, maybe your case manager or counselor. The issues were really exacerbated during this time, including transportation, where things like, even taxis and other, Uber just stopped working in many cases. So at the same time, there were some facilitators there where programs went into action and did partner with a transportation provider. And the issues of racism, again, and those that come up. If you go back, again, this is the time of George Floyd, Breonna Taylor, and everything else. We have seen a lot of destabilization in our patients. And a couple of those instances had to do directly with hospital police and clients expressing frustration of police directly towards them and having to navigate that. So again, how do you cope with that? You cope with the challenge of the substance use disorders. At the same time, how do you access care under these conditions? These regulatory changes revealing specific cultural contexts that may impede service delivery. The funding and reimbursement structures also may not support the person-centered decision-making. So this came up in many of our interviews, where both the patient flexibility was seen as a barrier, the losing the leverage of those in treatment. They thought they were losing the ability to be effective, while at the same time, others might say this is an opportunity to value clinical expertise and allow patients' preferences to come through. But this particular provider said no consequences for some patients who act out. Lack of leverage during COVID to get patients into different modalities or treatment that they may need. Again, allowed for refocus away from the take-home struggles. You know, that flexibility, often some programs get into these conflicts with their clients around controlling how the medication may be dispensed, rather than really focus on the issues before them, the behavioral issues, the mental health issues that may need to be, and the recovery issues that are needed. The flexibility again, here with a facilitator, not to be punitive, but to be client-centered and to have the patient preference in the frame. The fast track into harm reduction programs, those advocates for harm reduction for years and decades have been saying, look, make us a priority. During COVID, they did become a priority because people were dying. And what could they do when treatment may not have been available? So the combination of wearing masks, putting on gloves at the same time, if you're going to continue to use your drugs, maybe you'll use fentanyl test strips or other ways to test your drugs to make sure you stay alive. So the partnership between harm reduction and treatment providers really combined. Those buprenorphine prescribers, for example, really coupled together with harm reduction programs at this time. And finally, on the organizational level, the inner setting of the organizational, facilitators here were mentioned, that the group work became solution focused. So the staff came together to be a solution to adapt together to the new regulations, and they felt bolstered by that camaraderie. Even this open to change. This particular provider said, I don't think I'm as weighted down by the old school like my supervisor who's been there for 30 years. She has had a hard time with the whole concept of like tossing out all the rules and regulations and going with the waiver. But she said afterwards, she was so glad we did this because we didn't move fast, and we didn't move fast, and we got things taken care of. So again, morale and also staff issues were really important during this time, and really show a highlight and on what we need to do going forward around how do you retain staff, how do you take care of staff, especially as burnout became and morale very, very challenging during this time as people were working overtime, multiple roles as people left their jobs during this time. So right now there's a real emphasis on how do you keep staff in the substance use field, how do you engage them, and how do you encourage them to want to work in this field. Reimbursement, really critical in this area, and we're going to see how policies may change and regulations to make facilitation of reimbursement and parity between mental health and substance use continue to have that. Also making sure that the regulations for FQHC and OASIS license programs are the same, that Medicaid is describing the same kind of reimbursement that you're hearing from OASIS, so that programs are not confused by, for example, how long a session needs to be in order to bill for it. I mentioned earlier the bundled rate versus the client-specific service rate. We need to have innovative solutions here. We also, what about incentives for those patients that maybe are stabilized or not as stable around staying in treatment? What about how we help patients deal with co-pays during this time? The loss of group revenue really became an issue, as I mentioned earlier. And then how do we make sure that our essential workers in substance use programs are taken care of when it comes to having protective equipment, because they felt as if they were slighted during this period. Finally, peers have become so central to this work. The challenge of making sure they're able to bill for their work, to be reimbursed in the same rates and ways that clinicians are when it comes to telehealth. That's another issue that came up. The morale and the way they're seen as essential workers during a healthcare crisis was very confusing to many providers. On the one hand, they were seen as essential. On the other hand, they were not seen as healthcare workers. So people were confused about how they should take care of themselves during this time. So just finally, in summary and discussion, we see in this data that telepractice is feasible, it's effective for a broad range of substance use disorder services. We see the providers open to that. We see that technology and access is really critical, but we need to make sure we're improving access to ensure equity. Group treatment is a bit less amenable to telepractice, and certainly need to be think about how to reimburse for that. Regulations allow for a person-centered care approach. The clinical expertise and patient preference really are highlighted with flexibility, including treatment planning and outreach for those with co-occurring disorders, transitioning from one setting or criminal justice or mental health setting. There was some data around mental health clinics being closed. So clients came to substance use treatment programs saying, look, can you help me? We need change management approaches to make sure while change is happening, that organizations and staff and cultures are changing so that we can be more innovative and be effective with the clients we're serving. The economic stability of our treatment programs needs to be addressed so that it doesn't hinder patient-centered care. And the workforce in this area is needed. We need to build it and maintain it, and they need to be seen as essential and be reimbursed for that. Just quickly to point out a limitation, this again was a sample drawn from a non-random sample from this programs that were licensed in New York State only. The bias may be present because these volunteered from this particular sample, and it represents their views, not the organization. And of course, we're not ensured that people of color or people with voices of those who were active substance users or with lived experience, they're not necessarily guaranteed as part of this sample. So, and finally, I leave you with this: maintaining flexibility for clinical expertise and person-centered care is really critical. System change to address equity, destigmatizing treatment approaches and sustainable approaches for SUD are needed. And finally, urgent need to address the social determinants of care that we've been highlighted, not only in this data, but also the data mentioned from Dr. Henry and Bennett. Thanks so much. We look forward to your questions later.
Thank you so much, Tim. Appreciate it. So we'll have Amar bring up his slides now. And Amar Mandavia is a doctoral student in the clinical psychology department at Teachers College, Columbia University, and currently a clinical fellow at Harvard Medical School, Beth Israel Deaconess Medical Center, and our final presenter of the day. Amar, take it away. Thank you.
All right, thank you, Dr. Campbell, and thank you everyone else for bearing with us so far. I think we're right near the end, and hopefully we can kind of bring the story together here by presenting some of the findings we found from our survey that we conducted. And what I'm hoping to do today is kind of present on two different studies that we conducted. Let me see if that moves forward. There we go. All right, so just a brief outline for today. I'm going to be discussing two different studies that we've done at this point. One, which has been kind of referred to before, which is the survey that was conducted. And then we have some pilot findings and a GIS-based or geospatial study that we're going to present on as well. Just to start with an overview, just to help kind of frame the questions of what we're going to be talking about today. It'll be helpful if, as we're going through this, there are two main questions I think that we're trying to address. One is really around what are some of the policy level changes that the organizations want to support, or what are the providers that the organizations might support, or the administrators might. And the first study is really trying to take that bottom-up approach to understand what at the ground level are the things that have changed that people actually want to keep in place. And our hope is that in the second study, building on that, is going to be, okay, from a top-down approach, what is it really that has, where are the problems really located, or co-located even in this case? And considering the audience today, it would help as we're going through this, if you can think of an organization that you might be a part of. Each one of us is a member of either a department, a family, an institution of some kind, and it will help to keep the questions and the topic here much more relevant, just because if you have something more relevant to yourself in mind. And when we're looking at the more geospatial things, if you can kind of imagine your own neighborhood that you're living in, and maybe that can kind of give a bit more context and richness to the findings that we have here. So the first study itself that we're looking at is really looking at what are the support, what are the different policies that were implemented as a reaction to the COVID-19 pandemic, and what was the providers and administrators' support towards them, and specifically which ones do they really want to maintain or not maintain. Now, as a part of this, what we were really hoping to do is understand, okay, the pandemic is hit, and there's a quick response that happened, as a lot of the other speakers have kind of identified, to the need to kind of have more flexibility in services, increase access, and kind of really start looking at ways in which that information kind of flowed from top down of, okay, if there's a pandemic going on, we need to kind of make sure we reach the people that we're serving. And what the first study here is really trying to look into is saying, okay, how was this information really disseminated? And what we're trying to do here is really look at different organizational and staff level factors, like what was it about the organization? Was it the type of services they provided, the kind of programs they had, and where it was located? Did that have an impact on the likelihood of these services really being implemented, or actually even being desired as being something that's being maintained even? That not only do we want these changes to be made, but also could you keep them in place as we go forward? And what prior researchers had really identified is that oftentimes the likelihood of something sticking or not isn't just up to the organization, but actually what's inside the organization and the people that make up the organization itself. As you can imagine in your own life and the organizations you're a part of, that just because there's a change that comes from the top down doesn't mean that everyone's on board with it, or even everyone understands it, or if everyone even got the message or not. And so what we're trying to really do here is understand, okay, what are the different ways in which people within organizations and organizations as a whole who provide substance use service treatment react to these different changes that have been made in the policy. So to reiterate again, kind of the main aim of the first study itself, we're going to be working to describe the different patterns and levels and support for these changes to substance use policies that have been made. And to do this, as has been kind of talked about a little before, we kind of created an online survey that was really informed by the Quality Enhancement Research Initiative, which really looks at finding ways to actually understand the organization as one entity itself. Your kind of unit of analysis there, and what you're trying to study is the organization as a living being in some regard. And so you're trying to see what are the things that are making it up, what are the things that, and how does information flow in and out of it, but then also what are the decision-making processes that exist within a given organization. To help us do this, the wonderful people at OSS actually helped provide us a very comprehensive list of all the certified programs in the New York State area and contact information for them. And we were able to get support from the Harm Reduction Coalition to get information for harm reduction programs that are existing in the New York State area. And what we did was kind of combine this all together and send out this extensive survey that we had created with the hope of really getting a better idea of some information just about the respondents themselves, whether or not they were administrators or staff members, and also getting a bit of information about the organizations they were representing and the kind of services that they provided there as well. So what we did email the survey out, we had about a 50% recruitment rate. We're about, out of the 690 or 691 emails that we sent out, about 358 actually started the survey. And the main question that we're addressing here is about which policies to maintain. So that was about 14% through the survey itself. And we at that point, we had about a response rate of about 32%. And so for the findings that I'm going to present here first, we're going to be really looking at that part of the sample, which is about 227 individuals. And to make sense of really the choices and not just the choices, but the policies that they want to maintain, we're going to be looking at kind of doing some basic univariate analyses, multivariate analyses, and then finally to kind of account for this heterogeneity, right? This idea that I could support one policy, but maybe not the other, and not everyone in the organization or every type of organization is going to want the same kind of policies to be kept in place over time. We're trying to apply an analysis that's really going to be able to look at this heterogeneity within an individual itself and within an organization, so that we can actually look at the differences that might come up and not really silo people just in one bin or the other. And to do this, really what we did was we asked one specific question, which was, which policy changes would you like to see retained? And we gave about 21 different responses, which were generated from a desk review that we had done to see what were the policy changes that have been made so far, and asked these respondents to answer based on what they think the organization would like. So framing that as a kind of frame for the study, our initial results, just to show, you can see kind of the map of New York State here, and all those little tiny blocks are little census tracts, and the little dots within them represent our sample itself. So we had the larger OASIS sample, and then we had our subsample within that we reached out to. And our main kind of key finding here, and we're going to kind of stay with this figure for a little bit just because it has actually all the 21 different policies that we're talking about here. We see that, and they're ordered from the ones that were most endorsed at the top, working all the way down to the ones that were not as likely to be endorsed to be maintained after, let's say, the pandemic stay-at-home order stopped. And so we see that mostly around 80% of respondents, or actually first, let me just describe our respondent sample itself. Actually, of the 227 individuals we had, about 78% of them self-identified as administrators within their organization, while about 22% of the individuals identified as providers or staff members providing clinical care. And now, while there is some overlap between this, we did treat them as kind of mutually exclusive categories so that we could kind of get a better understanding here. And what we really saw that the most likely to be endorsed as kind of the policy to maintain even after, let's say, the pandemic's over or with stay-at-home orders are over, is the idea of really expanding the coverage from insurance. The idea that, you know, whatever the services that we might be giving individuals, it doesn't have to be just limited to in-person services, but actually not only expanding the coverage of what insurance covers, but then also expanding behavioral health counseling visits to be including in virtual format as well, and not just limiting them to in-person formats. And the next one kind of piggybacks a little bit off of that, which is the third point here, which is expanding these reimbursements for these televisits too, which kind of is subsumed under this larger expansion here. And then the other parts that really come into play is relaxing a lot of the previously pretty strict criteria around medication management and access to MOEDs. And this has again been highlighted by a number of the presenters here today. And the survey kind of really does corroborate the same findings there. Now, one of the other questions that we wanted to ask is that, was there necessarily a difference in the level of endorsement between the administrators and the providers? Were their priorities different? Was there a difference in the policy that they would have liked to see maintained? And so when we looked at the administrators compared to the providers, we saw that the administrators were significantly more likely than the providers proportionately to want these four policies to be maintained after the stay-at-home orders were completed. So specifically, they had to do with the expansion of insurance coverage, as we mentioned, increased virtual behavioral health visits, and expansion of reimbursement. And then also, interestingly enough, they were more likely to want to maintain or have the opportunity to keep observing medication administration through live videos itself. You can see a clustering here of kind of the similar ideas of things that have to do with the admin side of substance use treatment kind of being something that the administrators were more likely to endorse. And then on the converse side of it, we see that providers were much more likely than administrators to endorse retaining street outreach teams for patients who were homeless, to make sure that the people who were most at risk were still being served even after the immediate stay-at-home orders were closed off or changed. So now we take this figure here and we kind of look at this and say, okay, we're seeing some level of differences between administrators and providers, and that's kind of two categories we've created. But are there naturally occurring patterns in the way people are responding to these questions that we can kind of isolate based on their responses? So to better kind of figure that out, we basically conducted this latent class analysis, which basically tries to come up with ways of identifying patterns of which policies the respondents endorsed as wanting to be maintained over time. Specifically, what we're seeing are three different classifications here, and we oftentimes call them typologies, which is really indicating three different types. So the first being kind of high endorsers, which is individuals who are very much likely to ask for most of the policies to stay in place. We have the low endorsers, so the bottom who are saying, okay, really, I'm not sure if any of these should be kept. Let's see how it goes. And then the middle one, which is actually about 50% of the sample, which was saying, actually, I'm pretty selective. I'm not saying everything should be kept, but I'm also not throwing everything out. Kind of like a little bit of a Goldilocks example where there's just the middle ground there. Now, one of the things here was that all of the three classes were significantly different from each other for all of the different policies, except for three different ones. Specifically, these first two, there was no significant difference between the selective and the high endorsers, meaning that if you were very likely to want to maintain a policy or very selective, there probably wasn't a big difference in your desire to keep expanded insurance and virtual behavioral health visits. And the other side of that was there wasn't much of a difference between video recording of medication administration between the selective endorsers and low endorsers. Now, one of the things we really wanted to understand is why or how are these different? Like, what is unique about these individuals who fall into these different classes? And for this is where we kind of ended up running some of our regression and ANOVA analyses to really see, okay, what other characteristics that were previously identified in the dissemination framework as being pretty pivotal in whether or not policies are endorsed or not endorsed. And what we really found was that above and beyond the effect of what type of services they provided, whether it was inpatient or outpatient, whether it was treatment or prevention, or the provider's occupation, how many years they've been there, regardless of all of that, the only thing that was able to distinguish between those that were very likely to want to maintain a policy and not was whether or not this person actually had any knowledge of this change. Now, you can think about yourself in some examples of the fact that if you know something, if you've been given information about something that's going to change, you're more likely to want to endorse it because you might have a better understanding of it, but also because you're making much more of an informed decision there about it, perhaps. And what we really saw that while most of the respondents did want to keep these expansion to healthcare services and financial coverage for these services alive and well, the biggest difference was whether or not you actually knew about the changes that happened or not. And that really distinguished whether or not you were likely to endorse it or not. So this kind of brought us to the end of like the first study, which really brought this together of like, okay, so these are the policies that we would like to see maintained. So the next question that came up from there is like, okay, what is the actual landscape of the problem here? We're saying that these are the policies that have been changed immediately as a response to COVID, but we don't really have a good picture of what exactly was going on the ground that really was becoming a key barrier for clients to come in to receiving treatment. So one of the questions that we did pilot in that survey was actually asking respondents, what are the major barriers they perceive their patients as experiencing in accessing care? And kind of we see a kind of a gradation here of choices, and we really asked them to rank their top 5 choices there. And to kind of quantify it a little bit, what we found was like primarily it was issues around housing, mental health addiction services, socioeconomic barriers, and transportation barriers were the key things that providers and administrators saw as hindrances for clients to actually receive the services that the organizations were providing. And in hopes of kind of contextualizing this in the larger frame of COVID and the opioid overdose epidemic, a part of our lit review really did find that actually in the reviews that have already been conducted, right, what are the relationships that we see between these barriers to these adverse health outcomes for these clients, and specifically, how do these barriers to coming into treatment really map onto pre-existing barriers that might also be risk factors for COVID incidents or drug overdose deaths? And what we really see is that a lot of the similar characteristics that these providers have found or have also been repeatedly shown in other reviews to be kind of geographically and spatially located as being good indicators of risk for morbidity and mortality related to COVID-19, but also being linked to increased overdose, drug overdose specifically. And in hopes of kind of really putting this frame together, one framework that's often been used to make sense of this is something called the Social Vulnerability Index. Now, this index really, the purpose of it is really to help, was initially created, at least as a reaction to disaster workers, to be able to say, okay, when a disaster hits, what are the places in a given area that's going to need the most resources from us? And because of that, this index, what it does is it tries to take 4 different domains here. One is of socioeconomic status, which is made up of kind of socioeconomic indicators like poverty, unemployment, education, and income level. And another one, which is household composition, another minority language and minority status. And then the final one is housing type, which again, the idea being that these are all different indicators at different levels that are that have been linked to increased occurrence of COVID risk and independently have been shown to be independently associated with opioid overdose or drug overdose. And so what we were hoping to do is kind of build on this framework by adding another component to it that was specifically incorporating the new risks that we are finding associated with drug overdoses. Specifically, it's this idea of having limited access to the care itself. As you can recall from a number of the providers' responses, both in this study, but also in the other qualitative studies, a big part of the issue was getting to the clients themselves and whether or not they were actually able to access the care they needed. So what we were hoping to do with this geospatial study is actually put together a map of the state itself and the distribution of the different resources that are available for individuals there. And to do this, what we did was really combined a lot of secondary data from a lot of different sources at specific down to the census tract level to see, okay, these little overdose vulnerability factors, these social vulnerability factors, when we put them all together, how well are they associated with drug overdoses and how well are they associated with COVID incidents? And incident here was really defined for us as the percent positive rates of COVID tests in a given area. And what we tried to do as a part of this is say, okay, can we first do an analysis to see, do the social and overdose vulnerability factors occur where overdoses most likely occur? And then do the social and vulnerability factors co-occur with COVID, where COVID most likely is to occur? And then do we see an overlap between the risk factors over these two different conditions that are often, that at least at this point, are kind of some of the biggest issues for people with substance use disorders. So as a part of this, we'll share some of our preliminary results because I know we're a bit short on time. For the first part, for drug overdoses, we saw that there were about 17 different indicators we were able to identify as being uniquely associated with increased drug overdose deaths. And what we also found was that there were about 27 different indicators that were associated with increased COVID incident. But what we were really trying to answer is, what are the shared items? What are the shared risk factors for drug overdose death and COVID-19 incident? And we saw that there were 3 specific factors. One was the socioeconomic status index, which again was made up of different things like, I'm just make sure I got that down. Made up of number of people who were below poverty, number of unemployed individuals, amount of income that a person had. And the second 2 that we see are actually the amount of how far away do people live from a given medical clinic, or how far do they live from an emergency service center. So what we look at when we mean by time here is, how far of a drive is it for a person to get to these services? And we saw that the further the drive was for people from different clinics or an emergency service, and the increased amount of socioeconomic disparity that was there, that there was an increased overlapping risk for both opiate overdose and COVID-19 incidents as well. So I'm going to pause there and just kind of bring all of the findings that we've talked about together, both from the top down, from the geospatial side, and the bottom up from the policy side, trying to kind of get an idea of, okay, how do we really look at these different barriers to access to addiction care, especially as they intersect with known disparities that we see both as being identified by providers, but then also ones that we see that are kind of geospatially located in the state at large. Okay, and I will pause right there. There's some references. I can share the slides if people want. And thank you, everybody.
Hey, Amara, thank you so much. Herculean effort there.
There's a lot of information, but
but very well presented. Thank you very much. We want to open it up to questions now for our panelists. We've had a few come into the chat. I would just say that, I think it's just really exciting to hear these multi-level perspectives about the intersection of COVID and substance use disorders, and starting to think about moving forward, what can we learn from this period of time based on these regulatory changes to really improve outcomes for folks. So one of the questions, I think that's a good one to just kind of start with, and I'll open it up to whomever would like to address it first. But Dr. Comer asked about what areas of change, if any, do we think are vulnerable to reversal? Maybe given some of the providers' comments, maybe given some of the information that Amar presented on what we'd like to see retained, and your sense of kind of policy decisions in general. I don't know if Brandy or Tim, would either one of you want to start off? Any that you think are vulnerable to reversal?
No, Brandy, I know that what we need is evidence, and hopefully today we're helping to provide evidence for effectiveness of the new way of service delivery, because I think the field still needs to be convinced. You hear those old timers, if you will, that are doing traditional medicine, especially in the OTPs. I think will likely revert back to the ways of doing things that were more familiar and comfortable. We need the evidence from them as partners on what really works when it comes to retention and care for those with opioid use disorder, and for those who need more face-to-face because they need a different type of support, They need the structures of the clinic. Then we need to know about those and provide an adapted continuum of care. And so I think showing that evidence to providers will help really reinforce the change. Maybe Brandy can add.
Yeah, Tim, I think all of that is definitely a lot of what we heard. There were some barriers to maintaining certain policies that were highlighted as well. So even like state level policymakers in New York who have a fair amount of power and control over what, the landscape looks like in terms of what the regulations are. They even said, our hands are tied. Some of this stuff is decided at the federal level. We're in conversation with Medicaid, for example, but there's a lot of decisions that are above our head, and we really need the entire infrastructure to be on board with something like changing reimbursement structures for Medicaid. And so they were optimistic that there would continue to be buy-in and that there would be evidence from studies like ours and others that would show the value in these changes. But there were some concerns around if there wasn't a lot of robust evidence that things might just go back to the way they were before, because it would take work to make some of these changes stick and work at lots of different bureaucratic levels that are, resistant to change because it's complicated. And so I think we've seen some sort of continuation and progress around thinking through how we can continue to be innovative, but it remains to be seen as well.
Yeah, I might echo just a little bit in there as well around if we were to use the data, we have to inform it. The least endorsed items by providers and administrators was related to mail-based services. So mailing out UTOX screenings, mailing out medications, those were, again, only about 20 to 30% of our sample at least endorsed it. And I would imagine that's probably because of some of these different vulnerabilities there might be to actually reversal of that, right? That mailing something out like that and consistently being able to maintain that is going to be quite difficult to do.
Yeah, and I do recall Amar hearing from policymakers and providers when I was doing some of these interviews that a barrier to mailing was that they didn't get any money for postage, but they also weren't paid for, there was no reimbursement structure really for it. So there was no infrastructure around that, even though it was allowed. What was the incentive?
Thank you. Bennett, I want to go back to you and your presentation. And I think an interesting question is, especially using secondary analyses and EHR and the limitations of that, accounting for overdose deaths versus COVID deaths. And if you want to just talk a little bit about that in terms of the data analysis from your end.
Sure, thanks. That's a great question. So this is something that that definitely comes up, and we want to make sure that we're not incidentally capturing patients who are dying from overdose in our sample. So we're very fortunate with the Insight clinical database to be able to look specifically at those patients who are die in the hospital for a COVID and during a COVID admission, which I think is going to be a more conservative estimate, but is still going to make sure that we exclude those patients, as well as those patients who die within 2 weeks afterwards. And I didn't mention, I want to go into like a lot of the details in our in the presentation, given the brevity, but of the patients that we had who had experienced opioid overdose in the last year, actually only 3 of them had died during the 2 weeks post-discharge. So nearly all the patients with that history are dying in the hospital with their COVID diagnosis, so having a really extremely severe COVID to the point that they're dying in the hospital. So really, this is an important sort of take-home point, and something that we're really fortunate to be able to capture with the Insight database that we were not able to with using only our NYU hospital system data.
Thank you. Brandy, we had a question for you related to from Shyam Mandavia, she asked if there were any discernible patterns in the rates of distribution or demand of methadone when there was a transition to delivery. So getting back to your point around some of the supply chain issues.
Mm-hmm. Yeah, I did see that in the chat, and I was trying to think through, since this was a qualitative study, we didn't have data that like tracked geospatial relationships like Mar was showing us, but we did hear anecdotally or from the policymakers sort of highlighting that there were some trends from their perspective, and they were tied to the things that Dr. Hunt was talking about. So some of it was like cultural issues. Some clinics were just sort of stuck in this, they didn't want to change. And then there were other things that were more logistic around like geographical infrastructure for certain areas. So like New York City had a much better infrastructure around the methadone delivery than a lot of other places. So there was like this rural urban divide. I think there's a lot of opportunity there to dig into that more. And so hopefully some of the things that Amar is looking at with the GIS study can help us dig into that and have a better understanding of really where we can target some supports, because I think that could be key, is getting supports to the right places.
Great, thank you. And I know we're just at time here. I just want to put a final question out to the whole group from Dr. Gilbert, and just kind of thinking through the disparities that we're seeing in terms of overdose among racial ethnic groups, specifically with Black and Indigenous people, and any thoughts around COVID specific factors which may explain that increase in overdose deaths, and maybe Amara, this is something that you touched upon here, and Dr. Gilbert suggesting, less likely to be able to access telehealth, for example, drug supply issues, contamination, increased psychological toll, given what we know about COVID-19 disparities. Just wondering if any of the data that you presented today start to speak to some of that, where we see that intersection.
Yeah, no, it's a really, really good question, because the way we've looked at it right now is the idea of race and ethnicity being considered as an indicator within this is just if someone is of a non-white status, and some of the work from the SIG team and others in our team have shown that that's maybe not the best indicator to understand the ways in which disparity might be impacting people. And so really getting a measure of what structural barriers and disparities might look like on the ground, rather than someone self-identified race and ethnicity, is a little harder to do on a larger scale at this. But I will say from the different indices that we've looked at so far, for drug overdose, race ethnicity based indices are still very much present. I think the COVID incident one so far, we haven't seen a similar spike and related to kind of the indices really associated with minority status and language barriers and so forth. And I think that there might be something to do there with the fact that the way we're counting for incident is actually based on the number of tests that are done and divided by the number of positive tests that are done. And this assumes underneath it itself that the populations we're talking about are actively engaged in the testing programs, and the correlation also that exists between testing and availability of testing and availability of health services. So I think there might be something there that's kind of pretty hard to disentangle at this point, but I think that that is a very, very valid question.
Thank you. Any other comments from the panelists?
Just to say, yes, Dr. Gilbert, everything you mentioned are both challenges and opportunities. We have a lot of work to do. Let the research point in those directions, but hear from those communities that did disengage from services or were not engaged in services, both historically as well as exaggerated by COVID. And let's see how we can improve both outreach and engagement and the way it's designed as well.
All right. Well, I think we will end it there for today. I know it's 5:30 and closing time. I want to thank our 4 panelists very much for their time today and sharing these data that are hot off the press in many cases. Thank you everybody else for joining today. And I'll just end with sharing this. It's another chosen sponsored upcoming Hadar lecture, which is happening on next Wednesday, November 3rd, if folks are interested. Steve Shoptaw talking about medications as foundation for stimulant use disorder treatment. So thank you again to our 4 panelists, really appreciate it. And thanks for everybody else for attending today. And we'll see you next time. Take care.